Well, a warm welcome to today's talk. It's Tuesday, the 22nd of March. Now, I'm going to use the example today from the FDA of Moderna applying to give a fourth dose of vaccine to all adults over the age of 18. Does this make any sense? Does this stack up in terms of benefit for the individual is what we're going to be looking at. And to put it mildly, we've got significant questions on this. There's significant questions that need to be answered, in my view, before we carry on with this, or before the FDA carries on with this. And we'll also be looking at something on excess deaths later on as well. So some quite interesting topics. Now, this comes from here. I'll just show you the original paper, Moderna News Details. Moderna submits amendment to the emergency use authorization for an additional booster dose of its COVID-19 vaccine in the US. Now, here we see they want to carry on, they want to develop the emergency use authorization. Well, my first question is quite simple. Are we in a COVID emergency? And the numbers in the United States are going down quite dramatically. BA2 is taking over from BA1, generating huge amounts of immunity. Hospitalizations are down. Deaths are going down. Are we in a COVID emergency? I really don't think we are at the moment. I'll let you answer that question for yourself, of course, but I don't really think we're in an emergency. So I feel we should be getting past this idea of emergency use authorization, because I'm not sure we're in an emergency. But anyway, let's carry on and look at this. Pfizer, of course, have put in an application to give 65-year-olds and older a fourth dose. That's one thing. Now, if we take this example for Pfizer wanting to vaccinate over 65s, I don't know that the evidence for that is in place, and I'm pretty sure, well, I do know that the clinical trial data for a fourth shot is not there, because we don't have any results for clinical trials on a fourth shot yet. So again, we can question the evidence that's based on, but it's not what I want to look at in this video. So we'll just leave that Pfizer application for 65s and over. This is request to the Food and Drug Administration for an amendment to the emergency use authorization. So we're still carrying on with emergency use. Now, I would have thought emergency use is for use in emergencies, and I really don't think we're in an emergency now. So I think we need to get away altogether from the emergency use authorization that we did need at one time, but I do not believe we need now, and I think you might agree. But some of you can come to your own opinions. To allow for a fourth dose of its COVID-19 vaccine, that's the Moderna vaccine, in adults 18 years and older who have already had 3 doses. So are we really saying that we're going to vaccinate healthy 18-year-olds who've already had 3 doses here? That's what this application is asking for. To be quite honest, I'm struggling with credulity here, that we will be vaccinating 18, 19, 20, 21, 22-year-olds who are completely healthy with a fourth dose, who've already had 3 doses and may well have already had the infection. This really is straining the science as I see it. So a booster dose of Moderna 50 micrograms authorised for emergency use in the United States for 18-year-olds. So they're already getting a third dose. So the booster dose there, that means the third dose. And make no mistake here, they are talking about a fourth dose. I want to give a fourth. Moderna have applied to the FDA to give a fourth dose to healthy young adults. Clinical trials are ongoing for Moderna's Omicron-specific booster. Do we need an Omicron-specific booster? I think that's very much open to question, whether we need an Omicron-specific booster, because we've had the Omicron variant going on for some time now. I'm just looking for my picture of it, of the virus. There we are. And the natural immunity, as we know, is going to generate antibodies to membrane protein, envelope protein, nuclear plasmid protein, as well as spike protein, and also to about 22 other antigens as well that will generate an immune response. So do we need this? I don't think we do need that, but it's being developed anyway. And also a bivalent Omicron-specific booster. So presumably this will have Omicron vaccine in it, and some other vaccine type in it as well, because it's bivalent. It's going to cover two things. But what they are, we don't know. We just know that one's Omicron. Well, at least I don't know. So, questions. Will the fourth shot increase antibody levels? So if we give healthy young adults a booster dose of vaccine, is that going to increase their antibody levels? You can answer that question now. And of course, the answer is yes, it will boost antibody levels. If you give an antigen, the body's going to produce antibodies. That's just the way it works. So it will increase antibody levels. Will that mean that you can give the vaccine and then a few weeks later take antibody levels and say, hey, oh, the antibody levels have increased? Yeah, of course. Of course. But what does that mean for long-term immunity? What does that mean for B cells? What does that mean for T cells? What does that mean for longevity of response? What does that mean for the stimulation of the T suppressor cells that can actually inhibit the immune response? It tells you nothing. So we need to move away from this superficial data because it will increase antibodies for sure. But is that relevant? Probably not. Because what we're interested in here is preventing severe disease, hospitalisation and death in those that are being vaccinated. That's what we need. That's what the company or the FDA, in my view, needs evidence of. So yeah, it will increase antibodies, but so what? So what? Is it an emergency for a healthy 18-year-old to get a fourth booster dose of the vaccine today? So is it an emergency situation? Are most 18-year-olds in the United States at imminent risk of severe disease, hospitalisation and death after 3 vaccine doses, after probably being exposed to the virus itself? Are they at severe risk from this? I'll let you decide. I don't see this as an emergency. If you're a young adult in the United States, do you feel this is an emergency? Do you feel this virus is about to cause severe illness, hospitalisation and death in you as an individual? Do you feel immediately threatened? I'll leave you to answer that question. So, is it an emergency? I don't think so. Can beneficial endpoints be demonstrated for the individual? Now, this is what we need to look at. Is this going to help the individual? So if an individual has this 4th dose of vaccine, is it going to reduce their chances of severe disease, hospitalisation and death sufficiently, more than the risks of giving the vaccine, to merit giving this, it has to be said, expensive vaccine? Can endpoints be demonstrated for the individual? Well, I wouldn't have thought so. What number would we require to demonstrate these beneficial outcomes? So what number? So the thing here is, in a clinical trial, what we have is we have an intervention. And that's called the independent variable. And from that we get a result. That's called the dependent variable. So we give the intervention, which in this case would be the vaccine, to see what is the result. And the endpoint there, we will be looking for reduced hospitalisations, reduced severe illness, reduced deaths. That's what we'll be looking for. But to have an intervention, we must have something to compare it with, because we need a controlled trial, so we need a placebo. So we have to do a controlled trial with an intervention and a placebo, then we can compare the results between the two. That's what we would need to do. But then we need to decide if there's a difference between the results for the intervention group and the results from the placebo group. And for that, we typically do a test, normally called a t-test. So we do a statistical test to say, is there a real difference between the results for the intervention group that got the vaccine and the results for the placebo? And that depends on 2 things. It depends on the numbers in the study, the numbers of people in the study, and the size of the effect. This is crucial. So to get a positive t-test to say there is a significant difference between those 2 groups, if it's something obvious like death falling out of an aeroplane at 10,000 after being thrown out at 10,000 feet, then we would need relatively small numbers to prove that. But if it's a more subtle effect, so if the effect, for example, is, just think of a random example, the effects of exercise on depression. Now, we know that if you take thousands of people and they do exercise, that is good for depression. But is it going to work for any one individual? Well, it may or it may not. It's a more subtle effect, and we have a more subtle effect, we need bigger numbers. So the more subtle the effect, the bigger the numbers that we need to prove it. And with an effect like a risk-benefit analysis for 18, 19, 20, 21-year-olds, especially young men who are perfectly fit, to prove a risk-benefit analysis for a very minimal risk very minimal risk that they have, especially if they've got prior immunity. I think you would need hundreds of thousands to show a significant effect, because we need to show that a p-value is equal to 0.05 to claim any significance at all, that a p-value equals 0.01 to claim it's really highly significant, preferably p equals 0.001 or even less. So that would be 95% probability of being a genuine result. That would be 99% probability of being a genuine result. That would be 99.9% probability of being a genuine difference between these two groups. So we would need huge numbers, and practically to show an effect this subtle, I just don't think that's possible. Well, not realistically. I mean, do you think you can recruit 100,000 people into a trial in the 20 to 30 demographic to demonstrate this? So huge is the answer to that. Will the fourth shot reduce T-cell immunity for internal viral proteins? So we want the T. So as we know, we've seen the previous diagram. We have the internal cellular proteins. So we have the we want a T-cell response to the membrane protein, the envelope protein, the nucleoplasmid protein, and all the other ones. Will that be generated? Well, would the study show that? Well, again, I would question whether it would show that. Because we tend to look at outcomes rather than the T cells, but we've just said that looking at the outcomes would probably be impossible. If someone has Omicron infection, will a fourth dose increase beneficial outcomes further? Well, again, I'm not sure that it will. Is it time to end emergency shortcuts and go back to randomised controlled trials? I think it is. Yeah, we'll give that a yes, shall we? It's time to end this emergency situation. Will there be a guaranteed fourth dose? So if a fourth dose is authorised, will there be guarantees that it won't become mandated once emergency use is authorised? That's an interesting question. I would hope the answer to this guarantees it won't be mandated, but you know, in a college situation, for example, could we see a college principal saying, well, the FDA said this is all right, therefore I'm going to mandate a fourth dose for you healthy young adults who've already had 3 doses of vaccine, probably 80% of whom have already had the infection. And the data that we've got, we're still pathetically struggling for data. We've had the data, and you'll be bored looking at this data because we've done it so many times. But the reason we're doing it is because we simply haven't had any more. This is hospitalizations, and we see that the risk, so it's higher you go up here. Here's natural infection, here's vaccination. So natural infection with a lower risk than people that have been vaccinated. And the line essentially overlapping for people who've had the natural infection and been vaccinated. So it looks like after you've had natural infection, vaccine is no further benefit. That's what that data is showing. And I'm still frustrated that we haven't got the full data sets of that from everywhere. So this is quite helpful. This is from Johns Hopkins. The approval system for vaccines and scientific data for vaccines uses scientific data and exacting standards to ensure it's safe. And they say review of the process includes the FDA requires rigorous testing of vaccine through a series of clinical trials. For a fourth dose, we don't have that. So I can't see how they can possibly approve this. To make sure they work and are safe before authorising or approving them to the public, well, again, yes, that's why we need the trials. The laboratories that conduct the trials are independent from the vaccine companies and the government, so it's not biased. And of course, a lot of the original work on this, or the original research, of course, was actually published by the companies themselves, which isn't really an ideal situation by any means. Now, as well as positive clinical trial results, we need to look at the risk and benefits, and the FDA need to look at this. Demonstrate that the benefits of a vaccine are greater than its risks for those who will be vaccinated. So here, the FDA would have to be satisfied that the risk-benefit analysis to the individual is positive, to the healthy 18-year-old young man, that they're going to get more benefit from this vaccine than they are from the risk that they have of the disease and severe disease and hospitalisation. And it's really going to be difficult to demonstrate that, I would have thought. But there's also continuing monitoring afterwards, which of course is true, and there's also ongoing manufacturing that needs to be contained. Not really a problem with manufacturing, that the manufacturing is pretty slick as we understand it. But the FDA may pause the administration of vaccines to do more studies. So when particular and ensure that the problem does not outweigh the vaccine's benefit. Has this gone on when problems of myocarditis came up in young age groups? Vaccination programs did continue. Manufacturing, as I say, not particularly worried about that. They can produce reliable product. In the UK, the fourth COVID vaccine is to be rolled out to about 5 million vulnerable people starting from next week. Now, again, what the evidence is for this being advantageous is not clear. And we don't have clinical trial data on this because we haven't done the fourth vaccine studies haven't been done. So this is really supposition. And of course, a lot of the vulnerable groups now have already been exposed to the natural infection. Remember, antibody levels in the UK have been as high as 99.5%. Now, I know a lot of that is vaccine induced. I know a lot of the vaccine-induced immunity wanes really quite quickly, but still a lot of those will have been exposed to the natural infection by now because the restrictions are so much down with friends and relatives visiting all the time. And now remember, 1 in 20 in the people in the UK is positive. If we tested everyone in the UK, 1 in 20 people will be positive this week. So that means that 1 in 20 people visiting care homes are going to be positive, therefore potentially transmitting the virus on. So I think we have to admit now there's going to be quite a lot of natural immunity already developed, even in the more vulnerable groups, and that just doesn't seem to be being accounted for. Joint Committee on Vaccination and Immunisation, JVCI, another dose of Pfizer 6 months after the third dose, care home residents over 75s, immunosuppressed over 12 years of age. At least we're not talking about vaccinating healthy 18-year-olds. Now, people will be watching this pretty closely. I think if the FDA does authorise this, it won't help their credibility, which is already, quite honestly, not where they would like it to be. Now, this last reference I put on here is about when we talked about excess deaths. Now, I'm going to go over to Jessica now in Australia, who's done a bit of an analysis on excess deaths in Australia, and asks a very good question. So Jessica's just taken the data, she's looked at it analytically, and she's also facilitated that through some very nice technology. So Jessica, thank you very much.
Hello to John Campbell, and thanks for the invitation to present this information. I hope it's of benefit and will help the conversation. And hello to whoever may watch this video as well. My name is Jessica Henderson. I'm not a statistician nor a healthcare professional. I'm just an Australian citizen who is very interested in numbers to do with COVID and have found something that I find concerning. There have been reports of other countries having high numbers of excess deaths in the last year or so, which are usually attributed to hidden COVID deaths. However, Australia has also had excess deaths, but I don't believe that we can attribute them to hidden COVID due to some interesting data I've found which might help. All the numbers I'll be showing here come straight from the Australian Bureau of Statistics or from the births, deaths and marriages of Queensland. If we compare the average deaths over January to February of 2021 to the same time period from 2015 to 2020, there was a 5.3% jump, which is an increase of 6,906 deaths. All the excess deaths were among people aged over 65 years old, as you can see by this graph. No excess deaths seem to be among people aged under 65. Now, any deaths referred to the coroner, so any suspicious deaths or deaths where there were a lot of questions, they won't appear in these numbers. These are provisional mortality statistics. So there may be some hidden numbers from younger populations there, we don't know. The causes of death are a little bit mysterious. Respiratory disease was down, cancer was up a little, dementia was also up a little. The tiny little blue line you see here, if I get my pointer, this little blue line here under the brown, is our COVID deaths. There were 990 COVID deaths in this time period, but most excess deaths were in other causes. In fact, deaths due to other causes went up by 11% in 1 year over the previous 6-year average. the most unique thing about Australia's excess deaths data is that due to our country's COVID-0 policies and also due to our ability to keep our border very safe and secure, we didn't actually have a large wave of COVID infections or deaths at this point. We had very high testing rates, especially if anyone submitted to hospitals for any reason, with a vanishingly low positive test rate, which suggests that there's unlikely to be many missed cases. If you look at these numbers here, you can see that in 2020 we had a short wave here, but then throughout 2021 we didn't really have much of a wave at all until September, October. And here it dropped a little again, and then we had the Omicron wave starting in December. This is the timeline of the excess deaths, and this is the thing probably the most interesting to me. The green line is the 2015 to 2019 average. The red line is the total deaths in 2020, which was actually down a little over at the previous average. And then the blue line is 2021. Now, the unique thing with Australia, just for those who don't know, 2020 was a lockdown year for us, but we didn't have a COVID wave, and obviously it was pre-vaccination as well. So it was lockdown, not really much COVID, and no vaccinations at that point. We actually had fewer deaths than previous years. And then in 2021, from the very end of February on to the end of 2021 was our vaccination rollout, which started off with the most elderly and at-risk people, and then over the course of the year rolled out to younger populations and lower risk categories as well. Next slide shows the daily reports of COVID-19 vaccinations. So you can see that we had the COVID vaccination rollout really started to take off in like the 5th and 6th month, heading really for the 8th month there, as you can see. Just remember as well that Australia really didn't have much of a flu season either, anyway, in 2021. Next slide. This is really interesting. This is specifically in Queensland now, which is my home state. We have a population of about 4 million people, and there was a spike of 9.59% in excess deaths over the previous 6-year average, which is about 3,000 excess deaths. I couldn't access these numbers stratified by ages or causes, but they are final monthly numbers, and they do encompass the whole year, unlike the provisional data I just showed. And this is how those excess deaths were spread throughout the year. The dark line on the right of each cluster there is 2021. And you can see how in the last, I'll just get my pointer out, in these months here is our normal flu season. You can see that the grey line and the light blue line here show previous bad flu years, which we didn't really get much of this last year. So that may be hiding more excess deaths. We don't know up in here. Next slide. This is the timeline of the excess deaths. You can see there was a spike in May, and it sort of continued on through here. Once again, this was the normal flu season, which we didn't get. All right, next graph. This shows the COVID hospitalizations and ICU admissions for Queensland specifically. If there was a correlation, you would think that you would see it on this graph, but I can't see it. Now, this is the really interesting, the really important statistic, in my opinion. There was a grand total COVID deaths in Queensland, a grand total of 7 deaths right up until the end of 2021. There were only 7 confirmed COVID deaths in Queensland in that time period, and yet there's actually excess deaths of 3,000 for that same time period. Once again, there was extensive testing of symptomatic people throughout 2021 with a low positive test ratio, suggesting there weren't many hidden cases of COVID. As you can see with that top graph, in December, cases did start to go up due to the Omicron wave, as you would probably have guessed. So we have a large number of excess deaths, representing an almost 10% spike in deaths over the baseline. I can't see how you could attribute that to COVID infections, when for most of the year we had very few COVID infections. Sometimes we had 0. This is my final graph. This was the Queensland COVID jab rollout, the 7-day average. I don't know if there's a correlation then. Once again, I'm not a statistician nor a healthcare professional. I'm just a concerned citizen who would like to know what's going on. So what has caused these excess deaths? What could it be correlated to? I think that the people of Australia do have a right to know. And I believe that people more knowledgeable than me should have a decent look at these numbers and compare them maybe to other countries where there are similar numbers in that pre-COVID waves with a high vaccination rate, and just to see if there are excess deaths in other countries as well. Thank you for your time.
Very interesting, Jessica. Thank you for that, and I agree completely. It's an excellent question. And it's one that should be answered because we have seen the increase in excess deaths around the world, and the Australian situation is somewhat unique because of the way that the pandemic's been handled there. So obviously I'm not going to try and answer that question. We'll leave that question kind of floating, but one for the Australian authorities, definitely. So excellent report, excellent use of technology as well, Jessica. Thank you, very good. And thank you for watching.